So this is day 2 of our course, and I've been given the challenge to talk about imagining image guidance in liver SBRT. And if any of you who've started to treat liver cancers realize imaging is a crucial part of the process for any radiotherapy treatment. And hopefully by the end of the seminar I can tell you, we don't need the best imagination if we have the tools that enable us to actually see the tumor. I'll first acknowledge many people who have been a part of the liver radiotherapy program at PMH in the past 10 years, and thank you in advance for all your contributions. I'm going to outline why focus on liver cancer, why SBRT, what's the rationale for IGRT, and briefly summarize some IGRT approaches and some selected outcomes. So hepatocellular carcinoma is an important cause of global cancer death. It's the 5th cause of cancer, 3rd cause of cancer death, and unfortunately 5-year survival rates are still very poor, less than 10% internationally. It's the #1 cause of increasing cancer death in the USA, so becoming much more of an important problem in North America. Many patients with liver-confined disease progress in the liver or the vasculature beside the liver, and it's a local regional problem. And many patients are unfortunately unsuitable for standard local therapies, and radiation has a potential large role to play in the treatment for many patients. Metastatic colorectal cancer, also important disease. The survival of patients with metastatic colorectal cancer is improving. Median survival has doubled over the past decade. Reasons for improved outcomes include improved systemic therapy, but also increased use of surgery or local therapies for liver metastases. Colorectal cancer metastases are cured in some patients with resection, 40 to 50% 5-year survival in most series. But many patients, again, end up with liver-confined disease, either refractory to surgery or other local therapies, or patients are unsuitable for surgery due to medical contraindications or surgical challenges. So what about non-colorectal patients? There's definitely a boom in interest of treatment of oligometastases, and this was described in the 1990s as an intermediate state of cancer between localized and widespread metastases, representing a low burden of disease potentially curable with local therapy. And in this very nice review in JCO, selected outcomes with surgery, RFA, or SBRT are described for not only liver metastases, but other oligometastases in adrenal glands, nodes, and in the lung. And cures have indeed been seen following local therapy for oligo liver metastases from not only colorectal cancers, but breast cancer, melanoma, renal cell sarcoma, lung cancer. So it's a really interesting arena of study. So why SBRT? Well, just first state, there are clearly many ways to deliver a radical dose of radiotherapy that may ablate cancers. The external beam radiotherapy techniques are perhaps the most widely available. Brachytherapy requires specialized expertise. There's very interesting data coming from Germany, but that's clearly not something that is widespread. Intraoperative radiotherapy probably has only very few indications, maybe in the operative setting. The radioisotopes, interesting, again, requires expertise, and it's an invasive approach. So of the external beam techniques, again, ions, protons, not available, high cost. The radiotherapy approaches, hypofractionation, perhaps something that's more feasible for most of us. So what is stereotactic body radiotherapy, or stereotactic ablative radiotherapy, sometimes referred to as SABR? Very conformal dose distribution, highly potent doses, high dose per fraction, motion management, requires image guidance, the stereotactic component of the SBRT, and it generally refers to a few fractions of radiation, 3 to 6. In US, billing code is 5 or fewer, and with fewer fractions, more convenient for patients and improved throughput. But these same techniques can in fact be used in whatever fractionation is best radiobiologically for patients. Is there a biological rationale for SBRT? Well, there are high dose per fraction effects. So when the dose per fraction is 8 gray or higher, there are some effects that have been seen that are not seen at standard fractionation. And some of these effects are summarized here. Injury to the endothelial cells that are supplying the tumor, and two mechanisms of injury that again appear more common, more likely with a high dose per fraction. Immune phenomena are seen again more likely with a high dose per fraction, and all of this could lead to not only local control but potentially the Absgolpal effect, where the distant disease outside the radiation field could in fact have a response even with a local therapy. So very exciting area of research. There are some downsides of SBRT. SBRT is more sensitive to uncertainties than conventional radiotherapy. That's geometric, dosimetric, contouring uncertainties. The planned radiotherapy doses are not the delivered radiotherapy doses, and this is, of course, any treatment, any radiation plan, but as we increase the dose per fraction, increase the conformality, increase the dose gradients, we're more sensitive to these uncertainties. And systematic errors in positioning could lead to a geographic miss, excessive toxicity, and/or reduced tumor control. So why IGRT? Well, just first start by borrowing a slide of a diagnostic multi-phase CT for a hepatocellular carcinoma patient. This is from Dr. Jang, a radiology colleague. And if you look at the hepatic arterial phase in the left and the portal venous phase in the right, you can see there's tumor in the portal vein. But of note, you need to have the delayed phase of imaging to actually appreciate this is a very, very extensive tumor. So you can imagine if we did not have appropriate imaging and delineated a small tumor, most of this tumor would be missed with radiotherapy. So for hepatocellular carcinoma, multiphasic imaging is crucial for contouring. And as one of my colleagues likes to say, garbage in, garbage out. So we could have state-of-the-art image guidance tools, but if we don't have appropriate imaging and contouring, those tools won't have the effects we want. This is an example of a typical SBRT plan. This is a hepatocellular carcinoma with invasion into the portal vein, being treated with 35 gray and 5 fractions, as shown with the pink isodose. And most often in our clinic, tumors like this are limited in the dose we can deliver by normal tissue tolerances. Either the volume of liver irradiated, or perhaps even more commonly, proximity to luminal GI structures such as the stomach, duodenum, small bowel. So there's a strong motivation for reducing the PTV, and we need advanced technologies in IGRT to do this. And in this particular example, you can see it is the luminal GI structures that limit the dose for this particular patient, and with a reduced PTV, we may be able to, in fact, give higher doses to the actual tumor. The clinical rationale for IGRT, dose response, leads to improved tumor control, but unfortunately, higher doses also lead to an increased risk of toxicity. And IGRT can improve the concordance between planned and delivered doses. So it will increase the chance of uncomplicated sustained local control. Unfortunately, regardless of the motion management strategies that we use to deal with breathing motion, shifts in the liver position relative to the vertebral bodies occur. And this occurs in patients treated with breath hold, free breathing, gating, compression, or tracking. So imaging at the time of radiation delivery, IGRT, is needed to account for these shifts. And this is some data from 2 experiences looking at breath hold reproducibility in Michigan and Toronto. Standard deviation of that distribution of shift of liver relative to the vertebral bodies. And you can see that there's a larger variability in day-to-day repeat breath hold than within the time period of a treatment fraction, meaning that daily IGRT is required, not just one day at the beginning or selected fractions. This is data from patients treated with free breathing or abdominal compression. You can see the intra-fraction change in the liver position relative to the vertebral body on the y-axis. And you can see the inter, so fraction to fraction variability on the left, and intra within the time of a treatment fraction on the right. And so you can see between fractions, occasional offsets of 1 centimeter are seen for some patients, whereas within the time period of a fraction, in our own experience for treatments 30 minutes or less, majority of change is 3 millimeters or less. But you note one outlier. And this patient, in fact, had capsular metastases causing pain. And interestingly, after his first 2 treatments, when pain responded, he had improved reproducibility and less intra-fraction variability for the remaining treatment. So what are some approaches that we can use to image guide and treat these tumors appropriately. There's a plethora of technologies. All have pros and cons. This is a summary of some of the tools available. There's MR image guidance systems in development and combined systems that are now in use. Just a summary that liver IGRT is challenging. As mentioned, we need IV contrast to see the tumor. The motion due to breathing, stomach filling has to be considered. There's shifts in liver position, as I mentioned, and organs can deform. There's many tools, so it's hard to know what tool may be best for certain situations. And of importance, we've learned a lot with our image guidance tools about tumor and organ motion, deformation, and unexpected changes. We need to have a surrogate for the liver tumor, and at the treatment council, that may be any of what's listed here, the whole liver, portion of the liver near the tumor, Lipiodol following TACE, fiducial markers, calcification clips, maybe even IV contrast at the time of imaging at the treatment unit. Intrafraction solutions, so solutions for continuous or frequent imaging during one fraction are most important if there's a long anticipated treatment times or we anticipate shifts due to pain or movement disorders. Solutions are listed here. Frequent or continuous imaging with fluoroscopy, for example, optical monitoring, transponders, or other solutions that can be complementary to 3D imaging. This is something that isn't widestream, and we in fact don't use this routinely now, but before we went to an IGRT approach, we did use this routinely at our units. Sometimes the beam itself may allow some soft tissue surrogate for the tumor that may be visible. And in this patient, for example, you could see the air diaphragm interface to have some type of reassurance as the beam is actually being delivered that we're in the right spot. Real-time tumor tracking is an option where the actual gantry will move with the patient as they breathe. And tumor gating, where the beam is on during only one phase of the breathing cycle, for example, exhale. And this is an approach initiated in Japan in 2000 by the Haikoda group, and now commercially available with unit gimbal that can move and in fact also do cone beam CT. So interfraction IGRT solutions. As I mentioned before, the shifts or the day-to-day setup changes are the largest source of potential systemic uncertainty. So correcting those shifts in liver position, most often most marked in the superior-inferior or craniocaudal direction, is very important. And planar or fluoroscopic imaging can be complementary to 3D volumetric imaging. This is an example of a poor man's IGRT, MV orthogonal imaging. And in fact, this is what we started with in 2003 in Toronto before we had volumetric imaging or orthogonal KV imaging at the unit. The diaphragm was used as a surrogate for the liver tumor and vertebral bodies to align patients. So simple, using older technologies, the DRR and MV portal imaging matched. It can correct for some of the offsets in the tumor position. And as we transitioned to cone beam CT, in our first group of patients, there was guidance using the MV orthogonal diaphragm approach, but we obtained cone beam CT in those patients. So it allowed us to then look back and say, well, how was the liver actually positioned using that type of Oldsband IGRT? You could see before any repositioning, there were offsets almost 20 millimeters in some patients in the liver position itself. But using that MV guidance approach, the great outlier were corrected for. And in fact, majority of the offsets are within 8 millimeters. But 1/3 of offsets in total liver position were more than 5 millimeters in size. So clearly, for small targets, high doses, in lesions in a deformable liver, we want to do better than that. So orthogonal KV fluoroscopy is one approach, and this can allow confirmation of liver motion and breath hold before every fraction, and it can correct for large craniocaudal offsets as I described. But even better is inserting a fiducial marker around the tumor, and we'll hear later about some strategies to do that. 3D volumetric imaging allows us to see not just necessarily the liver, but also adjacent organs such as the stomach that may be dose limiting. And Lipiodol following TACE is very, very useful for hepatocellular carcinoma IGRT. Volumetric allows quantification and planning for rotation and deformation of the liver and adjacent structures. It allows for visualization of unexpected findings and determination of accumulated delivered doses versus planned. So I think this is an important research tool where if we really know what doses we're delivering, we're going to have a better idea of what the true dose-volume relationship is for normal tissue complications and tumor control probability. This is an example early on of an offset that we saw that wasn't necessarily anticipated. So due to the baseline shift in liver position relative to vertebral body, when the patient was treated with cone beam CT and there was a liver image guidance, so these contours are from the planning CT and they're overlying the cone beam CT, so the liver matches quite nicely. But if you can actually see, the spinal canal is much closer to the liver with that baseline shift compared to the blue contour that shows its position at planning. And in fact, without accounting for that, that could have led to a higher dose than anticipated to the spinal cord. So now we in fact use PRVs or planning structure, steep dose gradients away from structures that we anticipate may move at the time of treatment. Another example of how volumetric imaging showed us a detection of a change in liver volume. This was in a clinical trial where patients were treated with 7 days of sorafenib, a tyrosine kinase inhibitor. And we found unexpected liver shrinkage. And this was something that hasn't been reported. We didn't expect it. We would not have known about it if we used a fiducial type of image guidance approach. So what about breathing motion? How do we consider that? This is a patient treated in 2005. You can see his cone beam CT during free breathing has artifact a little bit difficult to guide off. This same data set, when only those projections are taken to reconstruct the cone beam from exhale, you start to see a little bit more clear the liver, may be usable. But clearly, if that same patient has imaged and treated in breath hold, you can see it's much easier to anticipate how this liver could be used for guidance than the free breathing. We have solutions for all of these situations, but the ones with 3D cone beam CT in motion are challenging. Respiratory sorted cone beam CT is now available commercially. It allows automated breathing amplitude measurement and matching. And as I mentioned, I think one of the simpler solutions, stop and go cone beam CT, allows simpler manual matching or automated matching and easiest verification. It's something we use routinely in our clinic. This is an example of a non-sorted cone beam CT. And with respiratory sorting, you can also visualize the breathing and motion of the liver that day immediately before treatment as seen here. The yellow is the CT at planning in exhale, the red is in inhale. So if you look closely, you can see at the treatment unit, the breathing is similar to how it was at the time of planning. So we're going to change gears and just briefly focus on some selected outcomes. This is a list of some of the potential radiotherapy toxicities that are crucial to avoid. So radiation-induced liver disease can be fatal. Classic radiation-induced liver disease consists of aneuploidy hepatomegaly, ascites, elevated liver enzymes, and that's more common in metastases, and we have a much better understanding now about how to avoid that. But non-classic radiation-induced liver disease is less predictable, more challenging to avoid. And that may include anything from elevation of transaminases, reactivation of hepatitis, a general decline in liver function, thrombocytopenia. Also, we need to consider the common bile duct and luminal GI structures and chest wall pain and rib fractures. And there's a growing body of literature to give us advice about dose volume constraints and limits for all of these structures. This is an example of some dose volume constraint recommendations for liver to avoid liver toxicity. Liver toxicity is more common in patients who have underlying cirrhosis or viral hepatitis B. As the underlying liver function is worse, the risk increases. Liver metastases guidelines, as proposed by the Colorado group, you can save 700 cc's from less than 15 gray in 3 fractions is something used routinely. For hepatocellular carcinoma, there's different strategies to avoid toxicity, but I'll highlight one recommendation looking at I guess, maximizing the volume of liver that is spared from radiotherapy. Even in patients where 700 cc receives less than 18 gray, there's an 11% risk of decline in Child-Pugh score, and very steep increase in risk as that spared liver volume decreases modestly. So really we need to maximize or increase the volume of liver that is treated with radiotherapy. So the slash of low dose is probably important. Selected outcome, RFA versus radiosurgery. This is retrospective, but I think intriguing that significantly longer disease-free survival compared to RFA, 34 months versus 6 months for colorectal cancer. And there's a dose response. This is a pooled analysis suggesting a dose from 48 to 51 gray in 3 fractions for 1-year local control of 90%. Looking at accumulated dose with the volumetric image guidance information we have, as I mentioned, we might have a better idea of the true dose to the tumor. And this is work done by Mike Bellick, Anand Swamanath, and Christy Brock. And you can see when we look at the accumulated dose, there's actually a bigger spread in terms of the hazard ratio for dose response. So very interesting. Hepatocellular carcinoma is a responsive tumor, and this just shows a quite large tumor treated with modest dose of radiation, 33 gray and 6 fractions, with a sustained response, probably not ablated, but by controlling this tumor for some time, we hopefully can impact and improve survival for that patient. A more recent series from Japan for hepatocellular carcinoma, over 200 patients, mostly small tumors, 84% T1, mostly child A. Again, using relatively modest doses, 35 to 40 gray in 5 fractions, found 3-year local control and survival of 91 and 70%. Outcomes similar to RFA and surgery. There is a suggestion of a dose response, and this is one recent paper that reports outcomes in slightly more advanced liver cancer patients using 3 fractions, 33 to 60 gray. And you can see the improved survival and local control when higher doses were delivered. This was independent on a multivariate analysis. However, there was a correlation between the volume of tumor and dose. So the higher volume lesions tended to get lower dose. Radiation can also effectively treat hepatocellular carcinoma with portal vein thrombus, and this is an example of patient with relatively marked disease, and here's an example of the tumor invading the portal vein, very high alpha-fetoprotein, the tumor marker, and following radiotherapy, reduction in the tumor marker, and also a complete response following radiation. And just one slide summarizing our own experience, and many others have also reported impressive outcomes following radiation for HCC with portal vein thrombus. Our experience updated by Alexis Bugeaud and JCO recently showed median survival of 17 months. And the only 2 factors important for or predictive for survival in multivariate analysis were invasion into the portal vein, a known strong prognostic factor, but also the trial that patients were treated on. So the first 52 patients did far worse than the last 52 patients that we treated. And you can see the size of that effect is as strong as portal vein thrombus. So why could this be? Some possible reasons for worse outcomes in the earlier years. Well, hopefully we have improved our patient selection along the way, but we actually still treat pretty large, pretty aggressive, pretty end-stage tumors in our clinic today. We have definitely improved imaging at baseline for diagnosis, and perhaps that has led to improved contouring and less miss from our contouring. There are advances in image guidance, as I've talked about. We started with poor man's IGRT and now use state-of-the-art volumetric 3D and 4D cone beam CT. We've had advances in planning, and I think in general there really is a learning curve for liver radiotherapy, and something that hopefully we can shorten as other centers start up programs as we share the tips that we've come across from our own experience. So from this experience and promising results using radiation for HCC with portal vein thrombus, this has led to the phase 3 study through the RTOG 1112, that is randomizing patients with locally advanced hepatocellular carcinoma, unsuitable or refractory to TACE. So majority will have portal vein vascular invasion, to standard of care, which remains sorafenib versus 5-fraction SBRT followed by sorafenib. The primary endpoint is survival. We need international collaboration to make this happen. I think this is an important trial. And it does require modern IGRT credentialing and real-time QA. But I think it's worth the effort to develop a system, ensure that patients can be treated safe, and then we can show the maximal impact of our therapy radiation on HCC patients. So in conclusion, there is a strong motivation for daily IGRT for liver cancer SBRT. There are many IGRT solutions, but for all of them, there are some common themes, and perhaps the most important is that a soft tissue surrogate for the liver tumor itself is required, and daily IGRT before every radiation fraction is needed. IGRT increases the chance of uncomplicated, sustained local control. And with modern IGRT techniques, there is truly less need for imagining. Now, that doesn't mean we shouldn't be speaking and collaborating with our radiology colleagues. I think that's a crucial part of a successful liver SBRT program.